hyponatremia is one of the common endocrine emergencies which is encountered in pediatric practice, and this is one of those conditions which is quite important in terms of the overall clinical perspective and in terms of challenges in terms of diagnosis and management. So the key issues on assessment, and this is the etiology which is the matrix we'll follow, is it really hyponatremia? If it is hyponatremia, is it free water loss or a sodium loss? Finally, what's the cause? And we'll go from there. So if we talk about is it hyponatremia, the key issue is hyponatremia basically is a low tone situation. If your fluid tone is less, your fluid will go inside the cells. It will cause swelling of the neurons, and that is going to cause acute problems. If there is a rapid fall, you will have features like coma, seizures, and respiratory distress, which is acute severe hyponatremia. If it's a slower rise, slower fall, but its moderate features will be nausea, headache, and confusion. Now, identifying these symptoms is very important, because when we talk about treatment, you would need to know that whether it is acute, severe, or moderate, because the guidelines are different in that perspective. Now, as time passes off, there is extrusion of the osmoles from the cell, which then will basically try to adjust their size. There will be some chronic symptoms like weakness, cognitive disability, instability, vomiting. These will be the features which are there of chronic hyponatremia in that regard. But the problem will happen is that if you have a rapid correction, if your sodium level rises rapidly, and we'll talk about what is the appropriate rise and what is an inappropriate rise later on, you will have a sudden extrusion of fluid. There will be a shrinkage, so something which has gone up, and if your balloon is blown up and it becomes small, you will have destruction of that balloon. You can think of in a similar fashion. This is what results in an osmotic disequilibrium syndrome. So the features of acute features of hyponatremia are because of cell swelling. The chronic features are more like adaptive features, but correction will basically cause cell shrinkage, which can be a huge problem in that perspective, and we need to be very cautious in that regards. This is something which is quite important from that perspective to identify and evaluate. Now, the manifestations of hyponatremia will depend upon two things: the severity and the rate of fall. So generally, up till around 130, you will have no symptoms. Around 115 to 125, you have features of apathy, irritability, and nausea. Headache, drowsiness typically below 120, seizures around 115 and below. But if somebody was at 140 and suddenly becomes 125, will have much more symptoms than somebody who was sitting at 125 for quite some time. So the rate of fall is also very, very important determinant, and this is what determines whether you need to correct it immediately or not, whether a chronic adaptation has happened in that perspective or not. So this is something which you need to be evaluating in that regards. Now, one important group of conditions, particularly in infants, is with regards to salt wasting crisis, in which you have both deficiency of aldosterone as well as cortisol. They will have more dehydration, shock, hyponatremia, hyperkalemia, along with metabolic acidosis and hypochloremia. So then you start thinking of a combined effect. And as Pratik said, if you have isolated SIADH deficiency, mild hyponatremia, no hyperkalemia. If you have aldosterone deficiency, severe hyperkalemia, mild hyponatremia. If you have a combined defect, severe hyponatremia, severe hyperkalemia, and this is what causes salt wasting crisis in that perspective. Now, very important differential of the salt wasting crisis is a renal abnormality, because that will also cause hyponatremia and hyperkalemia. The condition, however, will have a volume which is increased, while in salt wasting crisis, the volume is less. So if you look at hemoglobin, it will be low in renal failure, high in the setting of salt wasting crisis. Uric acid plus minus in renal failure, because it can also cause hyperuricemia, but high in a salt wasting crisis in that perspective. Any local infection, obstructive uropathy, pyelonephritis can also cause a picture, which can also induce a transient resistance to aldosterone, what we know as PHA type 2, which is a transient form in that regards. Now, very importantly, what is hyponatremia? So sodium levels less than 130, I would say, is significant hyponatremia. Otherwise, people talk about 138 and 135, but what we are really talking about is less than 130. Very importantly, if you should always do via venous sampling, if you're doing from the capillary, it may be erroneously high in that regards. Importantly, conditions which are associated with hyperglycemia, hyperlipidemia, and hyperproteinemia will cause falsely low levels of sodium. If you use an ion selective electrode, the lipid and protein problems will be solved, but hyperglycemia will still cause a problem. So in somebody who has hyperglycemia, for every 100 milligram per dl rise in glucose, the sodium comes down by 1.6. So you have to use that in the form of corrected abnormality in that regards, and use this formula specifically to get a corrected sodium in that perspective. Now, once we know this is hyponatremia, the second big question is it excess free water or a sodium loss? Now, I already said that everybody, whether you have sodium loss or excess free water, will have a AVP excess. Whether it is a appropriate or an inappropriate is a questionable scenario in that regards. Now, this is important because management will be different. Here you will say fluid restriction. Here, if you do fluid restriction, it may be lethal in that regards. So what really distinguishes the two? The most important parameter is really the volume status in that perspective. So as we discussed, if you have hypervolemia, if you have low uric acid, your hematocrit is low, urinary sodium is low, you're dealing with a free water excess scenario, third space loss. If you are hypovolemic with high uric acid, high hematocrit, and lot of urine sodium, you are dealing with a sodium loss in that scenario. And so basically volume and urine sodium are the key, and uric acid is a surrogate marker of volume. Low uric acid means high volume, high uric acid means low volume in that perspective. Tests, as I discussed, potassium, uric acid, urinary sodium will really give you a diagnosis in that scenario. We would not need aldosterone or further in the initial phase. So we need to go step by step in that regards. Now, what is the cause of hyponatremia? Look at clinical pointers. Pigmentation will indicate adrenal insufficiency. DSD will suggest you 21-hydroxylase deficiency. Micropenis is a pointer of multiple pituitary hormone deficiency. So clinical examination becomes important. Now, I have already said that potassium is an important clue. If you have somebody with hyponatremia with hypokalemia, this is unphysiological. If you have hyponatremia, you expect the potassium to go up. If you have hypokalemia and hyponatremia both, you are losing both of them either through the urine or through the intestine. So look for drug history. Diuretic use will become important. Look at urinary calcium. If the urinary calcium is high, this could be a Bartter syndrome in the absence of diuretic use. If you have hypomagnesemia, you're dealing with Bartter and Gentleman. Of course, diarrhea you have to evaluate in that perspective. Now, this is interesting. If you have hyponatremia with hyperkalemia, what does it mean? There is a problem in either the kidneys or the adrenals in that regards. So look at the fluid status. If the fluid status is more, it's more likely a renal failure. Hypovolemia indicates a RAS defect. If you are or hypervolemic, you look at kidneys, you look at liver functions, you look at cirrhosis, cardiac disease, and other things. If you are hypovolemic, then you start looking at whether your problem is aldosterone deficiency or resistance, and then work up from that perspective. So as I said earlier, the key workup is volume, urinary sodium, potassium, uric acid. That's pretty much enough. Other workup, renin, aldosterone, 17-OHP is not required in a routine cases in most situations. When will it be required? I'll discuss subsequently in that regards. So if we now have a challenge of renal versus adrenal, so if you have hypervolemia, low hemoglobin, high uric acid, and low urine output, this is renal. Hypovolemia, high hemo concentration, high uric acid, high urine output, this is adrenal abnormality. So if you're confusing between renal versus adrenal cause in that regards. What about SIADH? SIADH is an important cause and something which is there for chronic hyponatremia. It is one of the most common causes. Now, we all know that as the plasma osmolality goes up, the urinary osmolality goes up in that scenario. So essentially, below a plasma osmolality less than 280, you hardly have any urinary concentration. This is normal, but if you have inappropriate urinary concentration, dilute blood concentrated urine, that is what is syndrome of inappropriate ADH secretion. If we talk more in perspective of actual numbers, If your serum is dilute, sodium is less than 135 and osmolality is less than 275, urine osmolality is more than 100 or urinary sodium is more than 25, you have SIADH. But remember, SIADH is a diagnosis of exclusion. If somebody has an adrenal problem, a renal problem, a thyroid or a liver problem, they may also have falsely diagnosis of SIADH. So all this have to be excluded before you diagnose SIADH. Very importantly, if there is hypovolemia, this curve shifts to the left. So in that scenario, again, you will falsely diagnose SIADH. So you should have a clear-cut absence of history of diuretic use or hypovolemia. So dilute blood, concentrated urine, normal adrenal, thyroid, liver, kidney, no diuretic use, no hypovolemia. That's what is SIADH for you in that regard. This is very important because in the first case we showed that if you do fluid restriction in somebody who has an adrenal problem, that may cause more issues rather than any benefit in that regards. Now, very important, if you want to make it more sure, if you give saline, there will be no benefit. And I already talked. The reason for that is that there is a high ANP and there is a low level of aldosterone. So as soon as you give any sodium, it loses in the urine. No point, that's not going to give any benefit in that regards. Now, often this is confusing whether it is SIADH versus cerebral salt wasting. You have a neurosurgical patient, somebody who has a CNS infection, a head trauma, you have hyponatremia, whether it's SIADH or cerebral salt wasting. Theoretically, very easy. SIADH is low urine output, cerebral salt wasting is high output, but often it may be confusing. So what is important is volume. If it's U or hypervolemic with hemodilution, and very importantly, uric acid below typically around 2 milligram per DL, that's more like a SIADH. While if you have hypovolemia, hemo concentration, high uric acid around 6 to 8, start thinking of cerebral salt wasting in that perspective. Very importantly, urinary sodium will be high in SIADH, but it will be much, much higher in cerebral salt wasting. Why is it important to differentiate between the two? Because SIADH management is fluid restriction. Salt wasting management is basically giving more fluids and sodium chloride. So this is very important in that regards. Now, if I summarize all the conditions and which tests will help us make the diagnosis, uric acid will be high in all unless the fluid is more in the setting of fluid overload or SIADH, where it will be low. Urinary sodium will be low if you have fluid overload, which is third space, or there is extrarenal loss. Otherwise, the urinary sodium will be high. Potassium, anybody with hyponatremia, with hypokalemia, think of a GI loss or a tubulopathy. Anybody with hyponatremia or hyperkalemia, think of a renal problem or a RAS defect. And hemoglobin, as I said, if it's high, it's hemoconcentration. Think of a diuretic use or fluid loss in that regards. One very specific situation is the situation of a neonate who presents to you with salt wasting. Again, here, the gender, the genitalia will give you a diagnosis. So if you have somebody who has XX-DSD, large adrenal, this is 21-hydroxylase, most common in that scenario. If you have abnormal genitalia, both XS and XY, this could be the rare 3-beta-HSD and POR forms. If you have a XY-DSD, it can be star defect with a large adrenal. On the other hand, if you have normal genitalia in a male with small adrenal, that will be adrenal hypoplasia congenita, while if everything is normal, this could be pseudo-hypoaldosteronism. So genitalia, adrenal size and aldosterone levels, aldosterone will come later, will give you a diagnosis in neonates who present you with salt wasting, because that could be a life-threatening scenario in that regards. So now whatever we have talked, we'll summarize into 2 slides about approach. The initial approach is to do basic things, exclude pseudo-hyponatremia, hyperglycemia, hyperlipidemia, hyperproteinemia, and renal failure. If all that is normal, look at volume status. If the volume status is more, we are dealing with third space loss, cardiac failure, liver disease, renal failure. If the volume is normal, look at thyroid and cortisol. If it is normal, this is SIADH. If it's abnormal, that's like a multiple pituitary hormone deficiency. If volume is low, look at urinary sodium. If the urinary sodium is low, this is gastrointestinal loss or rarely cystic fibrosis. If it's more, look at potassium. If potassium is low, it's tubulopathy and diuretic use, while if potassium is high, it's RAS defect, get in renin and aldosterone defect done. That will tell you the diagnosis. So as I said, if you look at volume, urinary sodium and potassium, 95% of your differentials are done. You don't need to do very many investigations in that scenario. Now, this is interesting. If you have a neonate who comes to you with salt wasting, first of all, exclude an infection or obstruction. Look at genitalia. If there is a usual genitalia with a palpable gonad, which basically would mean that there's no palpable gonad, you're dealing with a XX-DSD. This is clearly going towards 21-hydroxylase deficiency. If 17-OHP is very high, this is 21-hydroxylase. If it's borderline, this could be 3-beta or 11. If, however, you have got no palpable gonad, it will indicate the possibility of a XY-DSD with a salt wasting. Look at DHEAS. If your DHEAS is low, this is a proximal defect, as Pratik was talking about. If it's high, this is like a 3-beta hydroxysteroid dehydrogenase deficiency. If your genitalia is normal and you have a male, you look at 17-OHP because CH will often be missed. If it's high, this is 21-hydroxylase. If it's normal, do imaging. And if imaging shows small adrenals, that is adrenal hypoplasia congenita. If it is large, then you start talking about other things which we'll discuss subsequently. In females, 17-OHP low suggests star defect. But if 17-OHP is normal, then you go for aldosterone levels. If aldosterone is low, there is an aldosterone synthesis problem. And if it's high, it is pseudo-hypoaldosteronism. So from a neonatal perspective, I've given importance to genitalia, 17-OHP. This is pretty much what is required. If you have abnormal genitalia in a XX, it's typically 21-hydroxylase deficiency, rarely 11 and 3-beta. If it's a XY-DSD, then start thinking of rarer proximal defects. If genitalia is normal in a male, rule out 21-hydroxylase deficiency and then adrenal hypoplasia congenita. In a female, do 17-OHP. If everything is normal, look at renin and aldosterone. If renin and aldosterone is also high, that is pseudo-hypoaldosteronism. If aldosterone is low, that will be a synthase defect. So renin and aldosterone do not do right here. Do it at the end if everything else is normal. That is the crux of this whole presentation, to really make a very practical and a cost-effective approach in that regards. So now we'll run through a few cases. 12-year-old boy with DKA, high blood sugars, and what we found was that the sodium is 126. Now, this is classically abnormality, which is pseudo-hyponatremia. So for every 100 milligram per DL rise, we have to add 1.6. So we have to correct this sodium. And what we found, it comes as 135.6. So in a DKA, always correct the sodium. That becomes important. 3-week-old child with failure to thrive and severe hyponatremia. Now, if you have a severe hyponatremia, I can bet it's a combined glucoaminocorticoid deficiency. There is a failure to thrive, dehydration, high PCV, again suggesting adrenal salt wasting. Now, what we found here was there was a high urinary sodium and the potassium was high. And when we looked at the genitalia, it classically showed atypical genitalia. So this is a newborn who has a XX-DSD with a hyponatremia, hyperkalemia. This is a classical presentation of 21-hydroxylase deficiency. Not much of a doubt in that regard. 1-week boy with seizures, hyponatremia, and hypokalemia or a normokalemia. This is important because now people will say this cannot be adrenal insufficiency, but I'll correct that this can be a central deficiency, a ACTH deficiency. There's no dehydration. Fluid status is normal. Blood sugar is also low. So there is hypoglycemia and hyponatremia. I think the clue is already there. On examination, there is micropenis. So this is classically a case of multiple pituitary hormone deficiency. Importantly, cortisol of 125 may be reported as normal. Growth hormone of 4 may be reported as normal, but they are inappropriately low for the level of glucose, for the level of sodium. So this is classically a multiple pituitary hormone deficiency. So always think of MPHD in this scenario. Now, this case already we've discussed how a child with a central defect was diagnosed as SIADH. So whenever you are diagnosing SIADH, do a thyroid profile and do a cortisol before you make a diagnosis in that scenario. Now we have an 11-year-old boy with traumatic brain injury, admitted in the ICU, improved with management, now developed seizures. There is hyponatremia. The urinary osmolality is on the higher side. So what do we do? Now, this could be SIADH or cerebral salt wasting. The most important investigation is uric acid, and uric acid here is low. So this will go more in favor of a increased volume and SIADH in that regard. So I would say uric acid is a very, very useful test in anybody who has a neuro surgical or a CNS related hyponatremia to distinguish between SIADH and salt wasting. This again is a case which we highlighted. A 16-year-old girl with abdominal pain, diagnosed with SIADH, but very importantly, you have to look at the cause, what caused SIADH, and that turned out to be porphyria. So you have to go beyond just making the diagnosis. Dr. Linda is talking about what is about a case of very low sodium and normal potassium. This is an unusual scenario, and generally speaking, I have seen a couple of cases with severe MPHD who can present like that. Sometimes you can have severe SIADH because of a nephrogenic SIADH which can cause, but this is an unusual scenario. If you talk about sodium levels less than 110 or 120, that will be unusual. Usually 120 is okay. Less than 115, that becomes difficult. Dr. Rajiv Das is asking what would be the initial food in a 6-year-old child with body weight 20 kg admitted involved with Japanese encephalitis so that hyponatremia can be prevented. So generally, more people are more talking about in terms of more fluids which is appropriate, more physiological rather than the hypoosmolar foods. So Dr. Pratik, what will be your take on somebody who has a JE?
So initially, we are at a risk of developing hyponatremia. So more than the fluid, it is the regular monitoring of the fluid which we should do. Of course, normal saline, we can see whether how the sodium is dropping or rising more than exact fluid we are giving.
Generally, we should look at the maintenance fluid, whatever is recommended for anybody else. There is no routine recommendation to restrict fluids in that setting or to really look at different fluids. You monitor the sodium, that is more important because it may not develop in many cases. You will have normal, and then giving less fluid may be a problematic scenario. Dr. Rajib is also asking about volume status in kwashiorkor. That's again an interesting scenario. So then uric acid may be a role in that perspective that will give you a picture in that regards. It will behave more like a fluid third space loss scenario. So more like a CCF or a liver disease or nephrotic syndrome. Dr. Ashubu is asking when looking at rate of fall, what should be the interval between the requests? So generally speaking, that will depend upon the severity. I would say 3 to 4 hourly will be reasonable in that regards. If you're giving an infusion, then you have to be more careful, but 3 to 4 hourly is good enough. Dr. Subhash is asking low sodium, low potassium, the most common cause I would say would be diuretic use. That's what we encounter less in children, more in adults, but definitely that's the most important cause. Rarely diarrhea with inappropriate ORS will be the second scenario. The third would of course be tubulopathies, but diuretic use number one would be that in that scenario.